It is my pleasure to introduce our keynote speaker, Dr. Carol Huston. Dr. Huston is a professor emerita at the School of Nursing at California State University in Chico, California. She taught there from 1982 to 2019, and she was the director of the School of Nursing from 2010 to 2015. She has received many awards, including Outstanding Teacher. She's published 7 books on leadership, management, and professional issues, a total of 23 editions, as well as over 150 articles in leading professional journals. Her book, Leadership Roles and Management Functions in Nursing, is in its 10th edition and has been translated into 5 different languages. It's really an honor to have you, Dr. Huston, and we really are fortunate to have you be able to come back this year after our symposium was canceled last year. So we appreciate you being here. So with that, I'm going to turn it over to Dr. Huston. Thank you.
Good morning, everyone. Give me just a second here to pull up my slides. Can all of you see that? Thank you so much for such a kind introduction. I really am absolutely thrilled to be back and to be invited again to be a part of the symposium. 34 years, that's a pretty amazing accomplishment. And there are a lot of people that I want to thank. Karen, you've been really supportive, but also Nancy, Linda, Georgia, Jose, and the list goes on and on. So I just want to recognize and thank all of you who put on this conference and appreciate the support that you've given me and the many kindnesses I've already experienced. So my presentation today is really going to give me the opportunity to talk about some of the new and exciting technologies that are really coming into healthcare today. And I think that in so many ways, the theme for this conference really exemplifies the time that we live in, because 2 years ago, who would have thought of using Zoom presentations as one of our most significant opportunities to continue to stay connected? So we'll talk about these new and emerging technologies, but perhaps even more importantly, I'm going to talk about some of the skill sets and the leadership behaviors that nurses in particular really need to think about when we start adopting all these new technologies. And I want to share up front that when I talk about nurse leaders, I'm not talking about only those nurses who have any kind of official role or capacity. I'm really talking about all nurses, because I do believe that all nurses can and must be leaders in today's healthcare system. I'm also going to do a little bit of visioning. And I have to tell you that trying to predict the future is very humbling. I actually had my real first opportunity to do some significant visioning work clear back in 2005 and 2006 as part of Sigma Theta Tau. I had really an incredible opportunity to chair what was called the Futures Advisory Council, which was charged with crafting Vision 2020 for Sigma. And as a part of that experience, I worked with some of the world's leading futurists around healthcare, and it really was a life-changing experience. It particularly stimulated my thinking about how the world around us might be changing in terms of emerging technology, and whether I personally had the skill sets that I was going to need to work in this kind of new world, and could I bring it to my practice. So being technology competent really is a challenge for all of us. And that's because all of these new technologies really bring us unprecedented opportunities as well as challenges. And I hope that I'll get to talk about both of those. And finally, and perhaps most importantly for this conference today, all this interest in technology really made me step back and question sometimes whether technology might actually interfere with how we demonstrate caring in our practice. So the focus of this conference is really important, and the questions that are being asked have never been more pertinent than they are today. So clearly, we know that technology is just continuing to change the world around us. And just look at the impact that COVID-19, the pandemic, has had on emerging healthcare technologies. For example, we know that the pandemic has brought about real growth and likely permanent change to the healthcare system in terms of things like surveillance tracking and telehealth. In fact, Landai says that the COVID pandemic accelerated the adoption of digital health and virtual care by at least 3 years. And the rate of change that they expect is not going to slow down. Fisk says that there's going to be more change in the next 10 years than in the last 250 years. It also struck me as I was preparing for this presentation how much technology has already changed our lives in the last 3 decades. Now, some of you, in both good and bad ways, as this picture suggests. Some of you who are a bit older might appreciate my trip down memory lane. I still have a cupboard of 8-track tapes and cassettes. Some of you might not even know what those are. I was already married by the time that microwaves were created. And I had grown children by the time the internet really came into play. I can remember being a graduate student and going to the library and spending time just looking at the card catalog to try to find out if there was a journal or an article or a book that might be, available to us. And when I think now about how information is instantaneous and is accessible, right at our fingertips, it really is a remarkable change over what I think is not a long lifespan so far. So what kind of technology initiatives are we going to see in the next couple decades? And what skill sets are nurses going to need to have to be able to use all this technology most appropriately? And finally, what kinds of new leadership roles are going to emerge for nurses in a technology-driven healthcare system? So I'm going to start today by talking about 6 particular technologies. And I'll talk about, they're all listed here, but I'm going to talk about them individually. So the first is genetics and genomics. And it's really hard for me to believe that it's already been 20 years since the Human Genome Project actually started sequencing the human genome in 2001. We've learned a lot in the last 20 years about how genetics impacts both health and disease. And while there's still some gaps in our sequencing techniques, there's little doubt that genetics and genomic research is going to continue to lead to advances in the diagnosis and treatment of disease in the coming decade. It's also just as likely that we're not too far from having a medical checkup consist, at least initially, of a DNA readout. And this is going to allow us to practice precision medicine, which means that we're able to look at each person's individual genetic component as well as their lifestyle, and to determine not only how to best manage diseases, but probably more importantly, to prevent specific diseases in the first place. So this really will continue to change medicine in terms of replacing kind of a one-size-fits-all approach. Carol says that the healthcare system is actually going to transition from one which fixes people after they're sick to one where patients get treated for conditions that we know that they're likely to develop. For example, we're increasingly recognizing those genetic markers for breast cancer or colon cancer and prostate cancer, and trying to be a bit more proactive in terms of preventing the cancer from occurring in the first place. We also know that technology, particularly gene therapy, is going to continue to help us to prevent or reduce the incidence of diseases that are now considered untreatable. For example, gene therapy is going to continue to make significant inroads in curing cancer. And in fact, the National Institutes of Health suggests that cancer and maybe even heart disease deaths will diminish or disappear completely within the next 2 decades as a result of gene therapy. Technology is also going to significantly impact organ transplants because we're learning how to grow new organs from a patient's own tissues. Right now, we can already grow tissue, tendon, and cartilage from stem cells. But in the next decade, scientists think we're going to be able to grow organs. We also have already grown experimental bladders and larynx. But soon, and when I say soon, within 10 or 20 years, scientists think that we're going to be able to grow hearts or livers or kidneys or lungs and other kinds of major organs. And if you just think about this a minute, if we can grow organs from our own tissues and our own stem cells, the chances of rejection go down dramatically. So that's going to completely change transplant nursing. We're also already seeing stem cells being used to generate replacement cartilage tissue to repair damaged joints, especially for patients who have osteoarthritis. So that will greatly reduce the incidence of the need for total knee and hip replacements. We also know that Harvard is currently testing low-powered lasers that can activate stem cell growing in damaged areas of the body. And we've been using stem cells to grow new teeth. Since 2010, we have learned how to grow new teeth. And it now takes about 2 months to grow a fully functional and living tooth. And the newest research is, originally we were growing these in a petri dish, but now we're learning how to grow them right in a patient's mouth. So it may be likely that dentures become a thing of the past in not too far of the future. We're also seeing a lot of new drugs to treat cancer, and as well as vaccines. And we know that for some of these drugs and these biologic drugs, they really bolster the immune system. But for others, they actually use target cancer cells directly by using and injecting genetic material. The second technology trend that I want to just address today will be innovations that really continue to provide less invasive and more accurate tools for diagnosis and treatment. For example, if you're old enough, you may have seen the show Star Trek. This was one of my favorite shows when I was a teenager. And one of the characters on the show was Dr. McCoy. And one of the most amazing things that Dr. McCoy did is he would wave a beeper or a sensor over a person's body, and it would automatically diagnose what was going on with the patient. So this was real science fiction in the 1960s, but it could be a part of our reality in the not too distant future. For example, futurists are suggesting that we may have some kind of a similar scanning device that could be installed in our showers within 2 decades. So these scanners will be able to look inside and outside of our body to see if there's anything wrong and then alert us if there's something that we should be trying to get fixed. We'll also likely have tiny computer bits called microbots and nano devices that can be implanted right into our bloodstream. And these can not only identify disease process, particularly cancer cells or growths, they can also directly inject interfering RNA to destroy those lesions before they ever grow into a full cancer. In fact, one of the futuristic blogs that I read suggests by 2030, more than 90% of cancers will be cured as a result of this particular technology. In fact, some of the futurists are saying that this same nanobot technology could become the effective end of aging, as well as the reversal of our current biological age. Another application that we see of this kind of nanotechnology are smart contacts. So these smart contacts are filled with thousands of biosensors, and they can pick up early indicators of cancer. we already have these kinds of smart contacts in development. And one of the newest applications for them is that they're able to measure blood sugar in our tears. So we're seeing a lot of clinical trials around the blood sugar applications in South Korea, but also in some places now in the United States. We're also developing blood tests that can check for heart disease. These 23 gene blood tests, they measure the blood proteins that actually are linked to heart disease. In a recent clinical trial, the blood test was 85% accurate in detecting potentially harmful blockages among patients. So when you think about this, if we can do a blood test to see if people have heart disease rather than angiograms, which have a much higher risk, look at the reduction that we'll probably see in terms of patient complications. And one thing that's particularly exciting to me, because I have family members with diabetes, is that we are now developing prescription tattoos. These are external, that kind of look like the fake tattoos that my grandkids might put on, placed on the skin. And it allows us to measure a person's blood sugar without having to do a finger prick. So these little miniature tattoos are only a few millimeters in size, and they're called nano tattoos. And they're filled with nanosensors that have different colors. So in many cases, the tattoo itself may be orange in color, but the dye lights up when the glucose levels are high, and it becomes darker when the levels drop. So typically these tattoos are applied once a week. They're already being piloted at many universities throughout the country. Northeastern University in Boston was one of the leading people to put forth, but it's also being done at UC San Diego, MIT, Harvard. We're not yet using them as a full treatment modality for humans, but it's very, very close. The trials are certainly underway. They've also announced some new gadgets that they're working on that can fit right onto your phone, and your phone will have a sensor that you can place up next to your skin, and it can read your actual blood sugar level. We're also likely to see an increased use of magnets to treat major depression. These were cleared by the FDA in 2008. And while we don't completely understand yet how they work, we know that they deliver a small electrical current to the part of the brain that's been linked with depression. And we just had a large clinical study that found that the use of these magnets was 3 times more effective than a placebo. And perhaps more importantly, it had no serious side effects. In 2013, we also saw the FDA clear non-invasive, deep transcranial magnetic stimulation to the brain. So new research says that one half of patients reported a significant decrease in their depression with this therapy. And in 2018, they started using this treatment in clinical trials to treat obsessive compulsive disorder. We're also going to continue to see new scanning technology. It's just incredible the progress that we've made in terms of scanning technology, to the point where we will likely greatly reduce the need for exploratory surgery and some invasive procedures. We also are going to see more 3-dimensional printing. Now, I'm not sure how many of you have actually been able to participate in watching the 3D printing process, but it's pretty amazing. 3D printing involves scanning an existing object, which gathers the data necessary to print something on a 3D printer. And this bioprinter prints an object by adding layer after layer of material. And the materials can be things like plastic, glass, metal, or ceramics, but it can also be made from your own tissue or your own organs or your own stem cells. So this literally makes the body into a system of interchangeable parts. So today's 3D printers can already print simple things like skin or bone or muscle or cartilage. It's harder, though, to print solid organs because of all the massive network of nerves and blood vessels. But even with that, the printing of solid organs like hearts and livers is expected within the next 3 to 5 years. In fact, the first 3D printed heart is expected sometime this year. And in 2018, we saw the first 3D printing of a human placenta at the University of Vienna. This is really huge in terms of our ability to improve the quality of life for so many people. For example, even as early as 2013, we saw doctors and engineers collaborate to create a 3D printing of a prosthetic lower jaw. This is for a woman who had had chronic bone infections in her jaw, and it was implanted into an 83-year-old woman. We think that we're going to be able to create artificial limbs using this kind of technology, as well as custom hearing aids and dental fixtures. And right around the same time, again, in 2013, scientists at Cornell first used 3D printing to create an ear that's really similar to a natural one. So just think about the implications that this could have for a child who's born with an ear deformity, or for someone who loses an ear as a result of trauma. We are also starting to see bionic eyes. Bionic Vision Australia developed the first prototype of a bionic eye in 2012. Now, I want to make clear that these bionic eyes are not cosmetic. These are not glass eyes or eyes to replace somebody who's lost an eye for trauma or whatnot. These eyes significantly address and even are projected to correct blindness issues. This is particularly true for those that have retinal pigmentosis. So just know that there's some exciting research that's going on in that area as well. And I just thought that you might enjoy seeing some of these pictures that I was able to pull off of Google Images that show the kinds of 3D printing and the quality that we're able to do now in terms of creating replacement body parts. Another area of change that we're really going to see in the coming decade has to do with robotics. And in fact, I think that robotics is the area that's of technology growth that's most likely to impact the practice of nursing in the coming decade. And there are so many different robotic applications that I could talk about. And as you'll notice, I'm kind of just highlighting a lot of different technology because there's so many. Certainly, the COVID pandemic, again, has had an impact on some of the newest areas of robotics. For example, the development and use of autonomous robots that are using that germ-killing ultraviolet light to decontaminate rooms in 15 minutes. We also know that the pandemic really accelerated the use of RFID technology. For example, one of the most common applications we saw as a result of the pandemic is tracking how long employees wash their hands and how often. We can do this just by putting in an RFID technology device at the sink that can read an employer's healthcare badge or some kind of a tag on their name tag. So leadership teams can then use that information to track the washing of hands. Another area that we continue to see growth in terms of technology is in the area of biomechatronics. And this is a term which really means that we create machines that mimic how the body works. For example, it's very likely by 2025 that we're going to have pancreas pacemakers for diabetics. We'll also probably have mentally controlled muscle stimulators for stroke and accident survivors, as well as miniature cameras and microphones that we can implant directly into the brain for individuals who have developed blindness or deafness. In 2018, we saw the development of an implant that's controlled by a remote or wearable patch that delivers stimulation to keep open airway muscles during sleep. And if this technology really comes to fruition, we'll see the end of CPAP machines or the need for those. We also see robots increasingly being used in surgery because certainly their steadiness and their accuracy can be better than their human counterpart. But I also want to just point out the cost of this effort. One of the experiences that I've had over the last decade is being on the board of directors at our local medical center. And I don't think that I fully appreciated the cost for some of this kind of technology. A typical surgical robot costs about $2 million. And you have to have volumes that are high enough to really provide a financial return within the life of the technology. And that's in addition to all the ongoing maintenance costs, the instrumentation, the disposable equipment to maintain that, and service contracts that typically run anywhere from $100,000 to $170,000 a year. We also are going to see more robots in diagnostics and therapy. Now, it's hard to believe this picture here is a robotic breast examiner. I have to say, as a woman, this machine is a little bit scary to me, but there's no question that with this kind of emerging technology, the ability to be able to diagnose even the smallest change in breast tissue is just really remarkable. Perhaps an area that's really going to be significant to nursing, nurses really need to pay attention to, is the use of robots as direct care providers. For example, we are already seeing service robots be used and developed for care of caregivers, in countries like Japan, particularly for the elderly. Now, these robots can help with things like carrying and washing. Although they're not commercially available yet, we're not that far from seeing that happen. So it's these physical service robots. It's the use, though, of robots as mental health care providers that I think really brings some issues of concern to me and scares me just a bit, because they're already here and they're already being used. So one of the simpler types of mental health robots that we see is a little furry seal called Pero. But Pero is not your typical stuffed animal. It is fitted with sensors beneath its fur. It responds to petting and its whiskers, and it opens its eyes, and it moves its flippers, and it squeals with joy. It can also remember its name and change its behavior in response to how it's treated. Now, Pero has already been used in Japanese nursing homes, and it is used to care for the autistic. And it was also used in 2011 after they had the tsunami crippled nuclear power plant leak in Fukushima. So it's used to provide emotional comfort to patients. But what's really important here is that the follow-up test suggested that for many of these elderly, Pero became very much a emotional support, and it was very soothing to patients with dementia. But many healthcare providers, including myself, have expressed concern about the lack of emotion in robots. And we've sometimes suggested that this is the element that will never allow robots to replace human caregivers. But that distinction is becoming harder and harder to maintain. For example, we now have new technology, again, with Japan being the front runner here, that's resulted in a kind of robot intelligence known as Kenzai. And Kenzai literally means feeling, sensibility, emotion, or feeling. So Kenzai robots monitor human expression, gesture, and body language, and they listen to people. They can also sense human emotion by monitoring the pulse rate and perspiration levels of the person that the robot's interacting with. When Kenzai hears a word, it searches through its database of about 500,000 words, And then it displays an appropriate emotion to whatever words the participant is saying. For example, in some of the Japanese Kenzai robots, when it hears the word war, it frowns. When it hears the word sushi, it smiles. It's also really important to think about, do you think that you could have a therapeutic conversation with a robot? Well, most of us probably would have said no, but this is a picture of a robot and its creator. And when you spend time looking on the internet at some of these newest robots, they look more human than not. Some of these robots even have synthetic skin instead of plastic skin. So I'm not sure that I could have a therapeutic conversation with a robot, but I am sure that someday it may be very, very difficult to be able to distinguish man from machine. Here are a couple more examples of some robots. So when I look at these and I realize how similar they look to a living person, it brings up some ethical concerns, because certainly some of the population that these robots are used with may have difficulty differentiating between human and machine. So the possibility that we could accidentally deceive very vulnerable patients certainly exists. And some elderly and vulnerable patients might think that the robots are more capable of social understanding and feeling than they are. So the real question then is, do these type of mental health robots improve or further the problem of social isolation in the elderly and other vulnerable populations? And I don't think that we have thought enough about that, but the development of this area of technology is really going full speed forward. When we talk about robotics, we're also going to continue to see more and more highly refined simulation used as an adjunct for nursing education. Some of these newest robots, which are not inexpensive, they sweat, they cry, they turn cyanotic, they speak. But just like every other area of robotics, I think that nursing educators are really struggling with trying to figure out how much simulation is the right amount. When I look at things like the pandemic or a lack of clinical sites, there's no question that simulation has brought us unprecedented opportunities to continue to allow students to have really critical clinical experiences that they might not have otherwise. And we know from the National Council of State Boards of Nursing study that simulation can be a very effective learning modality. But the challenge is going to be, how much is too much? And how important is it to have that human, really true human interaction for students in developing the art of professional nursing and demonstrating caring, which is really such an important part of our nursing practice. So biometrics is a fourth area of technology that I see changing significantly in the coming decade. So biometrics is the science of identifying people through their physical characteristics: fingerprint, handprint, retinal scan. Right now, the healthcare industry is the single largest user of fingerprint scanning technology for identification purposes. But we are beginning to see facial geometry make inroads into healthcare, as are palm prints and retinal scans. I'm not sure how many of you realize that each one of us has an individual palm vein scan in our hand that's just as distinctive as our fingerprint. And it's practically impossible to replicate somebody's palm print. So most experts say that we're going to have biometric signatures absolutely commonplace by 2025 in almost all healthcare organizations. We have other kinds of technologies that are also changing the face of healthcare. And one of them is the electronic healthcare record. We know that electronic healthcare records give us unprecedented opportunity to access a patient's healthcare record 24 hours a day, 365 days a year across the healthcare spectrum from multiple providers. But there are a lot of challenges as well. One is that it's just not easy, nor is it cheap. The average estimated upfront cost for a multi-physician practice for an electronic healthcare record is 180 to 200,000. But then there's the additional cost of 80 to 100,000 in training. And that's just the first year alone. And that doesn't account for the cost of the hardware or the training. But it's the cost for hospitals that I want to make sure some of you younger nurses out there really recognize, because they're truly staggering. The 24 hospital Sutter Health in California paid out more than $1 billion for its electronic healthcare record. And the 38 hospital Kaiser Permanente cost $4 billion to implement its electronic health record. We also know that electronic healthcare records are difficult to implement. There's still a lot of debate about who owns the data in the system. And we know that there's enough different types of electronic healthcare records that sometimes it's hard to get computers to be able to talk with each other or to share platforms. We also know that some providers feel that electronic healthcare records actually pose some patient safety encounters because they interfere with the provider-patient relationship. And there are also some potential compromises to confidentiality. I can't tell sometimes if this is just like a resistance to change, but the pushback is really there in terms of complaints about inefficiency and productivity loss. But also, sometimes when we're uncomfortable with new technology, we lose this patient contact. And I think this picture is just really descriptive of one of the risks that we really have to pay attention to when we use technology, that the patient doesn't just become a series of yes or no data points. And finally, the last kind of snippet of technology before I start talking a little bit more about some of the challenges that we really face has to do with CPOE, computerized provider order entry and clinical decision support. So if you reduce CPOE to its simplest form, it's really a system that requires healthcare providers to type their orders into the computer rather than handwrite them. And certainly when you know, as a nurse for 40 some years, we know that medical errors are caused by a whole host of a number of things, but sometimes it's been because we've had difficulty reading a provider's handwriting. And when you can't tell where that decimal goes or you can't read it, and when so many medications have similar names, it's easy to see why these kinds of errors happen. So with CPOE, the provider is typing this, and that alone has been shown to reduce serious medical errors, handwriting errors by more than 50%. But cost is also a factor. The average cost to put in a CPOE system in 2020 is $2.1 million with annual operating cost of $435,000. So even if you buy an off-the-shelf CPOE package, there are a lot of cost in terms of customizing it for each individual hospital. You have to create significant numbers of order sets that are specific again to your hospital and have to be put into place. We also see clinical decision support kind of incorporated into a lot of the CPOE systems. And clinical decision support, in essence, is where providers have the opportunity to input data, symptoms, information about a patient into a database that can help them make a differential diagnosis. Then, once that diagnosis has been made and the provider inputs the planned treatment of care, particularly drugs, this clinical decision support can help them determine whether the treatment plan is appropriate according to best practices and the latest evidence. So it's really a remarkable system. And yet I do consulting sometimes with healthcare organizations that have told me that they have turned off their clinical decision support system because providers were concerned that it would result in some kind of cookbook medicine. It's troubling to me because if in fact this is based on the latest clinical decision support, I just think providers need to make sure that they have a really well thought out process in terms of bypassing this kind of system. So what kind of skill sets are healthcare providers going to need to really address all these new emerging technologies. There are a lot, but I'm going to limit my comments here to these three. And again, I'm going to talk about each one of them individually. The first is being able to use technology to facilitate communication and relationships, and particularly work. So, for example, we have seen the pandemic create so many online platforms that have allowed us to continue to meet with each other and learn from each other. But this hasn't always been the case. It was just 5 years ago where I really fought a battle within my university to hire an individual to do advising for our online RN to BSN program. But this individual lived about an hour from campus, but was extremely well qualified. And just 5 years ago, the response that I received was, we can't hire somebody who isn't here every day at campus. How will we know if they're working? So again, I see these kind of changes that have occurred as a result of the pandemic. And I think that they will continue to permanently change how we view work and the environment in which we're able to conduct our work. We also know that providers increasingly need to have more expertise about knowledge information, acquisition, and distribution. And that's because the rate of knowledge, information, acquisition, and distribution is continuing to multiply absolutely exponentially at an even faster rate than it is now. For example, if you take the time frame from 3000 BC to 1990, so that's about 5,000 years, that same block of knowledge that it took us those 5,000 years to develop is now doubling every 13 months. And according to IBM, the build out of the internet is going to continue to soon lead to the doubling of knowledge every 12 hours. And that doesn't even take into account the kind of growth that we're going to see as a result of artificial intelligence. We also know that clinical knowledge is now doubling every 18 months. So for those of you who are just beginning your life as a new nurse, just know that by the time you finish nursing school, you're going to have to already reboot your clinical knowledge. So what does this mean for me as a nursing educator? It means that we really need to continue to remember to try not to teach students facts, because those facts may no longer be facts in 18 months. We need to teach students how to think, how to problem solve, but perhaps more importantly, to how to access information, to access evidence, to access best practices, and to realize that this is something dynamic that will be a lifetime journey for them in terms of staying current in their practice. The internet is also going to continue to challenge our ability to keep up with current best practice. And it certainly is going to impact how we share information with our patients, because the internet has become a major source of healthcare information for many, many consumers. There are now almost 3,000 healthcare information websites. And an August 2020 study from WebMD said that they had almost 80 million unique monthly visitors. That's 80 million visits to WebMD every single month. So we know theoretically, when patients have more access to information, it has the potential to make them become what we call expert patients. But not all information on the internet is accurate, or is it current? And in fact, many patients don't understand the information that they read on the internet, or they just pick the parts on the internet that really fit the information that they're looking for. But they do spend a lot of time out there searching. So we also know that these emerging technologies are giving us new questions that we have to answer. Like, how are we going to protect the privacy around genetic testing in an electronic world where so many people have access to this data? Should we intervene when genetic testing suggests that there's the potential for an outcome that may not be bad, but may not be the desired result? For example, sex determination, or the inheritance of specific desired traits. We also know that providers are going to need a whole lot more expertise around genetics and genomics than we currently do. The average age of the practicing nurse right now is about 50. And for those of us that age or even a bit older, we didn't know very much about genetics and genomics at the time that I was in nursing school. And for many nurses in practice, unless they've made a really concerted effort to go back and to learn about this, it's an area of expertise that they may really need to brush up on. How many of you feel like you could go back and obtain a genetic family history or identify individuals who are at risk of developing some kind of genomic influence condition or a drug reaction, or help people make really informed decisions about their genomic tests and therapies, or even how to refer somebody to an expert in this area? Because the reality is that people are increasingly gaining access to information about their genome and their personal genetic sequencing. And they're asking nurses for help in terms of what they should do or who they should see with that. So how common is this kind of, consumer testing? More common than you think. You no longer have to have any kind of physician order. It's as simple as doing a saliva test and sending it off. And it's as inexpensive as $100 with results that arrive in a few weeks to a few months. So it's kind of hard to imagine, but more than 30 million people around the world have already had a DNA test. But even more shocking to me is that worldwide, the prediction is by 2025, more than 1 billion people worldwide will have had their DNA mapped. Now, this is a picture of a report from one of the leading consumer DNA testing companies. And it shows, if you look at this, a person's relative risk of developing specific diseases, as well as what genes they might be a carrier for. The report also suggests personal traits that you might have inherited, as well as what kinds of medications you might have a higher risk of having an adverse reaction to. So there's a lot of pretty complex information here for a consumer who doesn't have any kind of health background. Would you be able to appropriately advise a patient who comes to you with this kind of data? Now, this is really important. And I was kind of an early adopter. It's been at least a decade since I was genetically sequenced, but it's not something that should be taken lightly. And the reason I say this is I think a lot of people are stepping into genetic sequencing simply because they want to find out a little bit more about their ancestry, their ethnicity, whatever. But when I did this, even 10 years ago, I knew how important it was to talk to my daughters first because we had some family history issues related to breast cancer and colon cancer. I asked my 2 daughters whether or not if I was genetically sequenced, they wanted to know the results. And what I found was one who had children already said, sure, I'd like to know that for my daughters. And the other one said, not so sure. I haven't had my children yet. I don't know how that would impact that. So I don't want to know. But it became pretty quickly clear to me that if I had the genetic sequencing and it uncovered something that would require treatment, there was no way to keep that not a part of my younger daughter's life as well. So I think that these kinds of conversations and thought, do you really want to know what your genetic sequencing says? Do you want to know? Do you have the emotional support systems in place? And how might that impact other people who are currently in your life? So this kind of technology brings incredible opportunities for precision medicine and for better understanding, preventing, disease in the future. But I think it also brings a lot of questions and issues that we really need to think about. So I'm going to talk about 4 of those here in the last part of this presentation. But really, a number of them address, again, this tension that we have between the use of technology and caring or the human element. And that, I think, is probably actually one of the most significant challenge for healthcare leaders, Because we know that care through technology has a potential, at least, to be cold and dehumanizing. Robots generally reduce the amount of human contact, and at least at this point, they lack genuine sensitivity to people's feelings. We also, at this point, don't have any legal restrictions on the amount of time that vulnerable populations can spend with robots, nor the amount of human contact that people should experience. So these populations may be in need for special protection in terms of emerging technology. We also, and again, I think this is a real responsibility for nurses, need to make sure that the human element isn't lost in our race to expand technology. I personally still believe that the human connection is the art of nursing, and that nurses need to be actively involved in determining how best to use technology to supplement our care and not replace human resources. So one of the challenges we as nurses face is trying to figure out how to maximize the benefits of technology without losing caring. Professional nursing comes from both science and art, but it is the caring that is the art of nursing. We also have ethical considerations that we have to look at. Technology can really cause us to think about how best to balance dignity and autonomy. And we know that genetic research at least has the potential to kind of reduce people to their genetic endowment. We also know that when we start doing genetic enhancements, we have to be careful not to change what it means to be human. And yet, how do we protect the right of individuals to choose what technologies they can and should have access to? It's a little disconcerting, though, to me that sometimes technology mania has occurred without us asking some of these kind of critical ethical questions before we adopt the technology. And you have to at least think about cost. What makes new technology worth the cost? And what criteria should be used in purchasing and developing these kind of technology when there's some potential values that really have to be thought about? So I personally know that new technologies, without a doubt, are saving lives and improving the quality of life for many people. But I do worry that sometimes we create the technology first, and then that creates the need simply because the technology exists. It's kind of that old adage, if we build it, they will come. It's at least somewhat true in terms of discussing technology advances in healthcare. And when new technology emerges, we know that people feel like that they just have to have it. So again, this may reflect wanting more than needing. You have to question whether some technology should be developed at all. And if so, who should be able to have it, and what the unintended technology issues might be. So we have to be really clear about what problem we're trying to solve. We also need to make sure that we're continuing to look at the cost versus the benefits. So technology is one of the leading cost drivers in healthcare. And we know that as we continue to develop more diagnostic and treatment technologies, that they're very expensive. And we have to ask, is this eventually going to result in the need to ration other types of non-technology delivered care? And given the cost of technology, we have to really make some hard decisions about who should have access to them and how we are going to prioritize very difficult decisions about who should be able to have this access when others cannot. We also know that in many countries, access to technology is dependent upon the ability to pay for the technology. And there are so many healthcare disparities worldwide. There are even healthcare disparities in this country about this. And we also recognize that healthcare resources are scarce, even in highly developed countries. So how can we justify uncontrolled healthcare spending on technology when it may end up meaning rationing basic healthcare resources to others. Who's going to make these kinds of decisions? We also know that emerging healthcare technologies are posing other challenges, particularly around training. Who's going to be responsible to make sure that all of the healthcare providers working with technology are fully prepared? And who's going to continue to make sure that they maintain this kind of competence given the rate of change that we're seeing in the healthcare system? And finally, all healthcare professionals are really challenged to see that the use of technology is ethical. And again, I already talked about, for example, having genetic data that while it can lead to real better care and patient empowerment, there are a lot of ethical dilemmas still around how we safeguard personal information. And those emotional consequences of an untrained person discovering really sensitive genetic data that they may not really understand or understand the implications of. So Wada says that with the pace of technology growth, that we haven't begun yet to come to grips with what's ethical, let alone what laws or rules should be in place. But I think it's nurses that increasingly have to step up and ask the how and the why and of how technology should be implemented. What parameters need to be put in place? What skills do we have to make sure that we have first? And what are the important questions that we have to ask before we bring that in? And for that to happen, nurses have to be at the table. So there are roles that we're increasingly going to see nurses adopt here as we implement these new technologies. Nurse navigators to assist patients in navigating a pretty complex healthcare system. Nurse informaticists to help us with all of those challenges that we've talked about around the electronic healthcare record and CPOE and clinical decision support. Nursing ethicists to address some of these ethical questions we've talked about. Nurse geneticists or nurses with significant genetic expertise. Nursing policy leaders to sit on decision-making boards to assure that the nursing perspective is heard and that patients continue to be kept front and foremost and that caring doesn't take a back seat. And finally, nurse change agents. And certainly being a change agent is not a new role for nurses, but there's never been a greater need or call for nurses in terms of technology and healthcare reform. So in conclusion, technology brings us both great opportunities as well as some real new challenges. And I really love this quote. It said, the expectation in healthcare today is that a leader is able to develop new things, sometimes not even knowing what they were yesterday, and yet deploy those technologies in an excellent way. That's a real big challenge. It's hard to do in an environment that's as unpredictable as healthcare. So we have to begin now to think about preparing for new technologies. And we have to think about how these technologies are going to change how we practice. And we need to make sure, again, that caring is not lost in our race to implement the technologies. We also have to create new educational models and leadership development programs to assure that nurses have the competencies they need to address these new challenges and to take on these new roles that I just talked about. So in closing, again, technology offers us tremendous opportunities, but we have to consider what technology is best in each setting. We have to know how it should be used ethically. Providers have to understand both the opportunities and the challenges that are involved. And we have to make sure that the human element continues to be at the forefront whenever technology choices are made. So I think the challenges are apparent, but I think too, so are the opportunities. And personally, I think the future is so exciting. So I'm hope that I will be here to see some of the new exciting technologies that are just around the corner. And I thank you so much for being here today and listening to me. And I think we have time, just a few minutes for some thoughts, some questions, and some comments.
Thank you so much, Dr. Huston. That was certainly a very thought-provoking presentation. I do believe we have a lot of challenges ahead of us, but as you say, also many opportunities. So I think we're going to go ahead and open it up to questions. If you have any questions, please put them in the Q&A box at the bottom of your screen. And I think while people do that, I'd like to ask a question. And
Okay.
so, of course, I'm Associate Dean for Research, so it's going to be a research-related question.
Okay.
What do you see as some of the key areas of research that nurses should be focusing on now as this technology rapidly expands? Do you think, you talked about genetics, and you talked about simulation. It seems like there's a number of different areas that nurse researchers can play a role. What would you see as the most important areas that we should be addressing?
I think you identified a couple already, but I think perhaps even more importantly, I think that most research teams that involve healthcare technology should be interprofessional whenever possible, because I think that every member of the healthcare team brings a unique perspective about whatever the technology may be, whether it's around some of the healthcare innovations, research that I talked about at the beginning, some of the emerging technologies, whether it's simulation and how much time promotes the most optimal learning opportunities, whether it's around genetics or genomics. I think the point is that by having an interprofessional healthcare team as part of your research question, that you're much more likely to look at not only the benefits of the technology in terms of improving quality of life, but asking some of those really important questions. So I wouldn't say there's any one area, but I would say as a nurse researcher that whenever possible to use that interprofessional approach to look at that emerging technology from as many areas as possible. For example, if I was a nurse researcher and I was exploring technology, I'd want to have an economist on my team to help me look at cost. I'd want to make sure I had key clinical and administrative leaders that could look at rollout. I'd want to have providers that could talk to me about the efficacy and the efficiency of the treatments. And then I'd want to have ethicists to help me really look at, have we asked all the right questions in the right order? Long answer to a short question, sorry.
Thank you. That was very helpful. And I think, Dr. Connor, did you have some questions from the audience?
There's just, sorry, let me unmute my video. Carol, thank you very much. It was so interesting. And I do think that you brought up a lot of things that we need to think about. It's not so much as a question, but people have commented on the same things that you have commented on, which is about ethics and equity. And that concern for, we have all this technology, but will it only be available for the wealthy? Hearing aids were an example that Dr. Mickelfelder brought up, that it's been available for decades, right? And good ones, but still only affordable for some folks.
That's right. I think another really interesting example would be around prostate surgery and robotics. We've long done prostate surgery just through a traditional kind of cut or through some kind of laparoscopic method, which is relatively low cost. And when they started using surgical robots to do prostate surgery, what we found is that literally overnight, with the introduction of that technology, that the need for the robotic technology for prostate surgery literally quadrupled. And yet we continue to do some outcome research, which suggests that while the cost is significantly higher for the robotic surgery than the laparoscopic surgery, the outcomes are not necessarily better. And there are even some research studies that have suggested the outcomes might not be quite as good in terms of length of stay or recovery. And yet we're also seeing some real cost differences or cost inequities in terms of who's eligible or is able to have that kind of surgery. So you know, it's a very complex picture and a lot of questions have to be asked.
Thank you very much. And we have, we could probably talk about this, but in the interest of time, what I'd like to do for the other questions is maybe if you can answer them from the chat box.
I'd be happy to do that.
Perfect.
So I just want to say thank you very, very much. And it was such a pleasure to be here today and to be a part of your conference. And thank you for your kind attention.
Thank you so much, Dr. Huston. And I hope someday we can actually meet you in person.
Me too. I hope so. Thanks again for the invitation.
Okay.